welcome Dr. Thilo Tollner from Germany, talking about the German screening program. Is he online now or not yet?
Hello, it's a pleasure for me to be with you. Thank you very much for the invitation. My name is Thilo Tollner. I'm a doctor from Germany, radiologist, and I'm working for almost 20 years now in breast imaging and in the German screening program. And I would like to give you some facts about the German screening program and how artificial intelligence may help us to improve the mammography screening. So, the title of my presentation will be Mammography Screening in Germany and the Contribution of Artificial Intelligence. Whereas Germany, we are not so far away, each one from another. If you look at the whole world, I think Egypt and Germany is not that far. I think it's like 4 hours by plane. And I'm working in a small town in the north of Germany, an old medieval town. That's how it looks like. Some data about Germany. We have a population of 83 million inhabitants. The screening population are women from 50 to 69. This is about 6 million women. We have a participation rate of 50%, which means we have to perform 3 million exams every 2 years. And the cancer detection rate in the German mammography screening overall is 5.6 per mil. The screening in Germany is population-based. Every woman between 50 and 69 gets an invitation with a fixed appointment every 2 years. We have a lot of administrative factors to look at. Data protection in Germany is very, very high. So the data management is central, done by the administration. They also do the automatic scheduling and they send the invitations to the women. We just give time slots and they fill them up. So the woman comes to the examination. We take images of both breasts in 2 planes and then the woman leaves. She doesn't see a doctor, she doesn't get a result at this moment. After that, the screen images are read by 2 independent radiologists. If one of both or both have a finding, the case goes to what we call the consensus conference. This is a conference where several radiologists experienced in screening sit together, have a look at the images, maybe try to compare to priors, get other clinical informations, and then we decide whether we should recall the woman or not. The results are sent to the woman again with a letter, and so she gets a schedule for an assessment, or she will be re-invited 2 years later. Some facts about the German screening program. Germany is divided in 94 screening units, so each unit is responsible for nearly 1 million inhabitants. We have 375 mammography units. This may be mobile units too. This is where the images are taken. We have 188 responsible doctors, means about 2 per screening unit. These doctors are responsible for the quality insurance. They are responsible for the whole workflow, to have enough screen readers, to have enough rooms, to have enough stuff. So if something goes wrong, these doctors are responsible. We have 602 screen reading doctors. That means these are radiologists which are very specially trained, and they have to pass an exam every 2 years to be sure that they still get good screen reading doctors. 2,100 radiographers approximately. These are the people taking the images. In Germany it's mostly women working in this profession. 32 pathologists to examine the specimen taken during the assessment of the screening, and about 360 surgeons. In Germany it's the gynecologists who do the surgery on the breast. The participation rate in Germany is almost stable at 50%. Women who get their first invitation, they come a little bit less, but women who once got an invitation, they come back with a more than 80% probability. The influence of the screening on the tumor size in Germany is significant. If we look at the time before the screening, 2000 to 2005, there were only 14% of the cancers less than 10 millimeters and another 35% from 10 to 20 millimeters. So not even half of the tumors were T1 classified tumors, and nearly half of the tumors were T2 classified. During the screening, the small tumors, detection of small tumors increased to 35% for tumors less than 10 millimeters, 44% 10 to 20 millimeters. So it means the T1 tumor rate grew up to nearly 80%. Same if we look at the precursors, what we call the ductal carcinoma in situ. Before the screening, 7% of the cases were small tumors which were not invasive, so very easy to treat. And with the introduction of the mammography screening, this part increased to 18% of the detected cancers. If we look at the all-over incidence of breast cancer in Germany, we can see this is before the screening. Here, screening gets introduced, so we detect much more cancers than before. We detected here all the clinical inapparent cancers, all the non-palpable masses. And so once all these cancers, probably already existing here but not detected, were detected, the screening, the incidence, means the detection, decreases slowly, but it never gets back to the rate before the introduction of the screening. This shows as well in the decrease of the breast cancer mortality in Germany over the years. And there are some studies published recently showing the effects of screening, and we can see that in the screening population here we get this peak with the introduction of the screening, as I showed you before. But if we look at the higher level breast cancer, stage 3 and 4, we can see a significant decrease of these states in the screening population. So what we can achieve is a significant decrease of mortality, less 25%, a higher rate of DCIS detection, precursor detection, and 50% of the DCIS detected in the mammography screening are high-grade DCIS, so very aggressive precursors. We have a significant decrease of the states 3 and 4, and we could decrease the mastectomy rate to 29%. If we look to the future, in Germany, women will be included from 45 to 75. This means plus 50% of women to examine. We have some logistic problems there. We don't have enough radiographers and we don't have enough doctors to read all these mammographies. So perhaps artificial intelligence may help us. Will we change from the conventional classical radiologist to the future now with AI? What can AI do in screening? It may improve the detection, it may decrease the recall rate, so the false positive findings, and that is very important as well, reduce the workload. So one of the ideas would be exclude all normal examiners. The AI has several advantages. Screen reading is very monotone. Only 5 of 1,000 women have a cancer, and rare findings are difficult to detect. The positive predictive value decreases in proportion to the number of findings. The advantage is computers never get tired. But there are several studies saying AI is not better than the doctor actually. So it would be perhaps a good idea not to replace the radiologists, but to help them, to make them faster. There were several studies published in the last few years in the British Medical Journal. They found that AI is not better than the radiologist, and there was a big point that there are no prospective studies concerning artificial intelligence in radiology in general. And so now actually in Germany we are starting the PRIME study, a prospective study to look at the effects of artificial intelligence in mammography screening. This will be very interesting to have the results. This will be the first prospective study in this domain. Now I'll show you a little bit about VARA, the software we are working with. So we don't try to replace the doctor. What they call it, the decision referral pathway. So what AI can do is classify studies as normal. That means findings under a definite threshold, under a definite sensitivity, are tagged as normal. And all others are tagged as potentially suspicious. This means the artificial intelligence is not better than the doctor. SafetyNet finds out very few studies above a defined threshold which are tagged as suspicious. So potentially suspicious contains 2% of suspicious findings, means cancers. This is how it works. If we have a low suspicion level, the normal tagging will be high. There will be something where AI doesn't give a statement because we know it's not better than the doctor, and then there will be at least a safety net. If the AI is sure that there is a cancer, it will show you. So some studies already showed that AI may decrease the workload and lower the recall rate in screening. So working with VARA makes us much faster. If we look at the normals, which are 60% of all studies, the mean reading time is 28 seconds versus 50 without VARA, without artificial intelligence. The potential suspicious, we take the normal time, 50 seconds per study, and if the safety net triggers, so if the VARA finds a cancer, We take more time because we have to look at it, control it, verify it, and think about it. So the safety net helps a lot, but it takes a little time. If we look at VARA, we get a work list, which is already classed. We can choose all, only the normals, only the potential suspicious. So in the evening when I'm tired, I prefer to begin with the normals because they are almost normal with 98% of probability. This is how the viewer looks, the workflow. We have the actual mammography here, we have the priors, we have other priors here, which we can easily pull in to compare. If we have no findings, the report is pre-filled. So it says the breast density is already chosen by VARA. VARA has found a benign lesion, nothing else, says normal. So we just click enter and it's done. This is very fast. If we have a finding, we just mark it on the images. VARA automatically fills out the clock face, the side, and the size and the distance to the nipple. And all we have to choose is it a mass, calcifications, distortion, or anything else. If we say this study is normal and VARA gets some findings, the safety net will pop up and will say, please look again at this image, I show you where, and then you can decide again if you find that's normal or not. And in this consensus conference where we all sit together and see what the different readers found, there are only women with findings, we can see here the readers, they get their colors, and so we can see if they all talk about the same lesion or if somebody else detected something else, and then we decide how to go on. So what can we say? Actually, artificial intelligence reduces the workload and it finds supplementary cancers. It helps us a lot and speeds up reading, but it doesn't replace the radiologist, at least for the moment, because laws won't be like that. Thank you very much. Now I would like to show you some pictures. This is the mobile unit. This is the German unit version. It looks very technical, as you can see. We have other images from inside the Mammobil. You can see it looks like a small medical practice. Everything is in this box. If we look to Italy, it's much more comfortable. It's much smaller. Women waiting outside here. They have a nice view. At the North Cape, this picture is taken at 2 o'clock in the afternoon, but you know it never gets really day over there. And this is one photo from Philips. They showed the desert version of the Mammobil, and if you look at the cool units over here, the climate, it's very, very important because the detector of the mammography needs always a constant temperature. California version, always flower. And so now with this image from our clinic, I would like to say thank you very much for listening to me, and we will be there for the questions and answers for the Q&A part soon. Thank you and goodbye.